Hello, this is Dr. Ballard. We're going to talk about the neurological system, and I'm going to be going over the assessment of the neurological system today. So first of all, let's take a look at the nervous system. The nervous system has central and peripheral divisions, maintains and controls all body functions by voluntary and autonomic responses. The neurological system remains a critical way in the clinical decision-making process. So when you see someone who's having a problem, you have to decipher whether that person is having a cardiac problem, a neurological problem, have they had a stroke, is the patient with leg weakness or numbness having some kind of degenerative joint disease, or are they having some kind of spinal cord compression? Does the patient with nausea and vomiting need a gastroenterology consult because they just have maybe a viral gastroenteritis, or is it possibly meningitis? Do they need a head CT or emergency intervention? Are they having elevated intracranial pressure? So there are lots of similar questions that will frequently arise whenever we're providing care to patients that we come in contact with. And a neurological exam, a careful neurological exam, is critical to determining the basis of a lot of underlying disease processes. So when we examine the neurological system, we are going to check the following elements. We're going to be checking the motor function, sensory function, autonomic function, cognitive, and behavioral components. Make sure that you review this link that I've provided for you. This is a really good website that will give you some insight into a complete neurological exam. It starts with introduction and mental status, goes through the cranial nerves as well as the motor exam and reflexes, and then ends up with coordination and sensory exam. They also have a video. It's an excellent site. I would encourage you to take the time to browse through and go through each of these areas, because it will really help you understand it in a lot more depth. The NeuroExam is really, really important component of your complete physical exam. Now, when to use the neurological exam is always something that students struggle with. Do you do a complete neurological exam on every patient? Of course not. But those are things that you will learn over time. In this class, we're teaching you all of the assessment skills that you will need, and when you get in practice, you will be able to use those at the appropriate times. In this class, you'll be doing a complete head-to-toe physical, because we want to make sure and ensure that you understand and know how to do the complete exam. So when we do a neurological exam, we usually start head to toe, and we're going to check the cranial nerves, and we'll test them 1 through 12. Now, I know a lot of you have probably seen in the charts cranial nerves 2 through 12 grossly intact as a documentation. That's because cranial nerve 1 is the sense of smell, and most people kind of skip over that in the clinical setting. But if you were going to do a complete neurological exam, you would test all 12 cranial nerves. The neurological system will include cerebellar function and proprioception. We're going to evaluate coordination, both gross and fine motor skills, evaluating fine motor by doing the rapid alternating movements, how the patient is able to move their upper and lower extremities, the accuracy of those movements. We're going to evaluate their sense of balance, and actually it's more than sense of balance, because the Romberg test actually is used to be able to determine if the patient is able to know where they are in space, their position sense, more than it is just balance. So I want to make sure and clarify that Romberg is to evaluate a patient's proprioception and sense of where they are in space and not just balance. Observing the patient's gait, their posture, and the sequence of strides and arm movements are also critical in evaluating the neurological system. We also test for sensory function. There's primary sensory responses to either superficial touch and superficial pain. Also, the sensory function tests vibratory response to tuning forks over joints or bony prominences. And then we evaluate their perception of position sense with movement of the great toes or fingers of each hand also, of where their body parts are in space. Sensory function assesses the ability to identify familiar objects by touch and manipulation. This is called stereognosis. So if you were to put something like a key in the person's hand and they were able to tell you what it was, or a quarter or something like that, that's called stereognosis. Whether they're able to discriminate 2 points on their body is called 2-point discrimination. The ability to identify something that you draw on them is called graphesthesia. And then the ability to identify the body area when it's touched is called point location. We also test superficial and deep tendon reflexes. Abdominal reflexes and the cremasteric are more of your superficial. And then the plantar reflex and the deep tendon reflexes are your deep tendon reflexes. And then ankle clonus is another reflex. Just a little review, anatomy and physiology. So the central nervous system is basically composed of the brain and the spinal cord, and it's the main network of coordination and control for the body. Then we have your peripheral nervous system, which includes the cranial nerves and the spinal nerves, and this carries information to and from the central nervous system. The autonomic nervous system coordinates and regulates the internal organs of the body. There's 2 divisions that balance the impulses of each other, the sympathetic and the parasympathetic, which you guys can review that on your own. Just a little overview. The brain and spinal cord are protected by the skull and the vertebra, the meninges, and the cerebrospinal fluid. There are 3 layers of the meninges that produce and drain the cerebrospinal fluid. This circulates between an interconnecting system of ventricles in the brain and around the brain and spinal cord, serving as a shock absorber. And here's basically just the anatomy of the brain and meninges and the ventricular system. So the interrelationship of the nervous system allows the body to perform the following components: to receive sensory stimulus from the environment, to identify and integrate the adaptive processes needed to maintain current body functions, orchestrate body function changes required for adaptation and survival, integrate rapid responsiveness of the central nervous system with more gradual responsiveness of the endocrine system, control thought processes and voluntary behavioral processes, and control subconscious and involuntary body functions. Okay. I'm going to skip a couple of these because I think this is just review and you can review this on your own. Just remember that the brain does consist of three major units: the cerebrum, the cerebellum, and the brain stem. And here are the different lobes of the brain and the different areas. So the cerebrum is divided into the two cerebral hemispheres, each divided into lobes, and that forms the cerebrum. The higher mental functions occur in this area, the gray outer layer of the cerebral cortex, and allows general movement, visceral functions, perception, behavior, and integration of functions. The corpus callosum is that area of thick fibers that divides the two, and it's an interconnection between these areas that permits the coordination of activities between the hemispheres. The biggest part of the cerebrum is the frontal lobe, which controls voluntary skeletal movements, fine repetitive movements, control of the eye movements, and corticospinal tracts that extend from the primary motor area into the spinal cord. The parietal lobe processes sensory data, interprets tactile sensations like the sense of touch and temperature, pain, pressure, size, shape, etc., and the recognition of body parts and awareness of body position, in other words, proprioception. It also assists with visual sensations, sense of smell, hearing, and the communication between sensory and motor areas of the brain. The occipital lobe contains the primary vision center and provides interpretation of visual data. The temporal lobe is the area where perception and interpretation of sounds and integration of taste, smell, and balance occurs. Also, speech and interpretation of speech are located in the Wernicke area of the temporal lobe. So to keep that in mind. The basal ganglia is the extrapyramidal pathway and processing station between the cerebral cortex and the upper brain stem. The refined motor movements through interconnections with the thalamus, the motor cortex, the reticular formation, and the spinal cord. So all of this should be review for you. If you need to go back and look at the anatomy, I encourage you to do that. Okay, the brain stem, there's several, there's three main parts: the medulla oblongata, the midbrains, the pons, and then the diencephalon, or the thalamus. And then there's cranial nerves. There are basically 12 cranial nerves that originate from the brain that have both motor, sensory, and parasympathetic function. And here is a picture of the origins of the cranial nerves. This is basically a list of all 12 cranial nerves and a mnemonic that I learned and most people learned, and it's listed in your book, and then which nerve that actually stands for. On old Olympus towering top, a Finn and German viewed some hops. It's one of those things that you'll just have to commit to memory, but this may help you remember it. So the first O is the cranial nerve 1, olfactory, and that's your sense of smell. Cranial nerve 2, or optic nerve, is visual acuity, visual fields, and your ocular fundi. Cranial nerve 3 is oculomotor. It controls pupillary reactions and some of the extraocular movements. Cranial nerve 4 is the trochlear, which is the corneal reflex, and cranial nerve 4 is also one of the cranial nerves that is responsible for extraocular movements, and we'll go into those in more detail later. Cranial nerve 5, or trigeminal, is responsible for the corneal reflex, facial sensation, and jaw movement. Cranial nerve 6, or abducens, is responsible for one of the extraocular movements as well. So you can see that cranial nerve 3, 4, and 6 are all responsible for extraocular movements of the eye. Cranial nerve 8, acoustic, hearing. Cranial nerve 9, or glossopharyngeal. Part of is responsible for swallowing and rise of the palate. And cranial nerve 10 is the vagus, which is the gag reflex, and also part of the rise of the palate. Then cranial nerve 5, 7, 10, and 12 also control voice and speech. Cranial nerve 11, or spinal accessory, controls shoulder and neck movements. And cranial nerve 12, or hypoglossal, tongue, symmetry, and position. And there they are listed for you. I posted a little YouTube cranial nerve song on Blackboard for you. It might help you in understanding and remembering the cranial nerves, but if in any case, it was kind of fun. So if you have time, take a look at that. Another thing about the cranial nerves is to remember that they have either sensory or motor function, or both. So one way to help you remember is another mnemonic to help you remember whether this cranial nerve is sensory, motor, or both. And the mnemonic is, some say marry money, but my brother says bad business marry money. Another version of this that you might find more interesting is, some say marry money, but my brother says big boobs matter more. Your choice as to which one you want to use to help you remember. So, cranial nerve 1 is sensory, cranial nerve 2 sensory, 3 motor, 4 motor, 5 is both, 6 is motor, 7 is both, 8 sensory, 9 both, 10 both, 11 motor, and 12 motor. Okay. So the spinal cord is a continuation of the medulla oblongata. It ends at L1 or L2 of the vertebral column. So that's actually where the cord ends. Okay. Fibers grouped into tracts that carry impulses within this column. It mediates reflex activity of the deep tendon reflexes. These nerves exit and enter via the anterior and posterior nerve roots and the spinal and peripheral nerves. There are 5 segments of the spinal cord: the cervical, thoracic, lumbar, sacral, and coccygeal. So the cervical is C1 through 8, thoracic T1 through 12, lumbar is L1 through 5 and sacral S1 through 5. And then coccygeal is below that. That's the spinal column itself. Although the actual nerves end at around L2. Or the actual cord itself. Now when we look at the spinal cord and spinal tracts, you'll hear the ascending and descending spinal tracts. So the ascending spinal tracts are the spinothalamic or spinocerebral, mediate sensation, facilitate signals for complex discrimination, and transmit precise information about stimuli and location. Ascending spinal tracts are the posterior or dorsal column, carries the fibers for the sensation of fine touch, two-point discrimination, and proprioception. The spinothalamic tracts carry fibers for sensation of light and crude touch, pressure, temperature, and pain. These are your ascending tracts. The descending tracts, corticospinal, reticulospinal, and vestibulospinal, originate in the brain, convey inhibitory or facilitatory impulses to various muscle groups, and they play a role in the control of muscle tone, posture, and precise motor movements. Descending spinal tracts include corticospinal, vestibulospinal, and corticobulbar. We've got upper motor neurons. These are nerve cell bodies for the motor pathways that all originate and terminate within the central nervous system. Descending pathways from brain to the spinal cord, their primary role is influencing, directing, and modifying spinal reflex arcs and circuits. The upper motor neurons can affect movement only through the lower motor neurons. So an injury that results in initial paralysis, an injury of upper motor neurons can result in an initial paralysis followed by partial recovery over an extended period. Lower motor neurons, they're cranial and spinal, originate in the anterior horn of the spinal cord and extend into the peripheral nervous system. They transmit neural signals directly to the muscles to permit movement. Injury of this area of lower motor neurons results often in permanent paralysis. So there are 31 pairs of spinal nerves that arise from the spinal cord, and each one exits at a different area of the intervertebral foramen. Sensory and motor fibers of each spinal nerve supply and receive information in a specific dermatome, or this is a specific body distribution, which is what we call a dermatome. So basically where the nerve exits and goes out to the rest of the body is where that nerve will either transmit or receive sensory and motor receptors. So 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. So also remember the different roots, the ventral root, the dorsal root, and then peripheral nerves. We've got ventral root, which is motor fibers from the spinal cord to the body. Then we've got the dorsal root, which is sensory fibers from the body to the spinal cord. And then peripheral nerves are both sensory and motor. And you think about affect and effect. So Sensory is afferent and motor is efferent, meaning that they are affected or having an effect. Here's a picture of the cervical of all of the 31 groups of nerves: cervical, thoracic, lumbar, sacral. This is basically a descriptor or a picture of how these impulses are transmitted. Dorsal root is sensory, ventral root is motor, if you keep that in mind. So one of the things to remember about the nervous system is that we are usually evaluating it for a specific purpose, to find out if there is a neurological deficit, to find out if there's a problem with one of the spinal nerve roots or with the brain or some area in the nervous system. One of the things that I want you guys to remember is the term cauda-equina syndrome. Cauda-equina syndrome, or CES, is really a rare disorder, but it is a surgical emergency. So in patients who have this cauda-equina syndrome, there's something compressing on a spinal nerve root. That may need fast treatment to prevent long-lasting damage that may lead to permanent paralysis or incontinence. So cauda-equina syndrome affects a bundle of nerve roots called the cauda equina, or the Latin word for horse's tail. These nerves are located at the lower end of the spinal cord in the lumbar spine. So they tend to receive messages to and from the legs, feet, and pelvic organs. So causes of cauda-equina syndrome, they occur more often in adults, but it can occur in children who have spinal birth defects or who have had a spinal injury. The most common causes are a ruptured disc in the lumbar area, a narrowing of the spinal canal or spinal stenosis, a spinal lesion or tumor, a spinal infection, inflammation, hemorrhage, or fracture, a complication from a severe lumbar spine injury such as a car crash, fall, gunshot wound, or stabbing, a birth defect such as an abnormal connection between blood vessels or arteriovenous malformation. The symptoms of cauda-equina are hard to diagnose sometimes, and the symptoms can vary from very mild to severe, and they can also be sudden or can come on slowly. They can mimic other conditions. But you want to evaluate patients that have any of the following symptoms: severe low back pain, pain or numbness or weakness in one or both legs that causes them to stumble or have trouble getting up from a chair or out of a car, loss or altered sensation in the legs, buttocks, inner thighs, back of the legs, or feet that's severe or gets worse. They may have this trouble feeling anything in an area of the body that would sit in the saddle, like between the legs and thighs area. We call that saddle anesthesia. They may also have recent problem with bowel or bladder function, like trouble eliminating urine or waste, like retaining it, or trouble holding it, incontinence. And then sudden onset of sexual dysfunction. Those are all things that should raise a red flag and want you to evaluate further for this condition called cauda-equina. So one of the things that you want to always document on any person who comes in with low back pain is that you have evaluated for this emergency condition by documenting that there's no loss of bowel or bladder function, no sexual dysfunction, and that they are not having any numbness, tingling, or paresthesias or radicular type neurological symptoms. This is a good description and picture of the relationships of the neurons. And you can see here the dorsal root and the ventral root, and then the rest of these are actually like the lumbar, not lumbar, but spinal cord discs, the vertebrae, and the discs would be in between the vertebrae here. Now, one of the things that you'll be evaluating is the deep tendon reflexes. So it's important to remember where they are and what it is exactly that you're evaluating. They are an involuntary response, and each one involves specific segments of the spinal cord. The ankle reflex is basically the sacral area, sacral 1. The knee reflex is lumbar 2, 3, and 4. The brachioradialis is cervical 5 and 6. Biceps, cervical 5 and 6. Triceps, cervical 6 and 7. Abdominal, the upper area of the abdomen is thoracic 8, 9, and 10, and the lower is 10, 11, and 12. And then your plantar response is lumbar 5 and sacral 1. Knowing the regions associated with each deep tendon reflex will help you locate the pathological lesion. So it's important to remember what each one is checking. So looking here, this is just a picture of the exiting of the spinal nerves from the vertebra. Both the posterior and anterior view in the relationship of the spinal cord to the vertebra. You can also see here, indeed, this is basically the cauda equina area, the caudal area with a group of nerve fibers composing the cauda equina. That's where this area right in here. Sorry. Okay. Sensory pathways register pain, temperature, position, touch. The spinal thalamic tracts, pain and temperature, crude touch, light touch, posterior columns, position and vibration, and fine touch. We talked a little bit earlier about the dermatomes. It's the band of skin that's innervated by that sensory root of a single spinal nerve. Now they do overlap each other slightly, so that's why you can never tell exactly which nerve root it is, because they oftentimes overlap slightly, and oftentimes overlap slightly across midline. But it does help you localize neurological lesions if you learn the dermatomes. So I'd encourage you to look at this in your book. There's a good picture of the dermatomes. So looking here, C1, if you can look here, basically C1 doesn't really have any skin distribution. It looks so. But you can see C2, C3, C4, etc. And all the way down to the lumbar and sacral areas. So the more common, lower back type injuries are the L1 through L5. And so those are the things that you might most commonly see, and also like cervical radiculopathy. You'll see that quite often with people coming in with pain or numbness or tingling radiating out into their arms. So make sure that you learn these dermatomes. It's also one of the things that will help you, as we talked about earlier, like to help differentiate shingles, because that follows the dermatome, and you'll have a breakout of the rash along one of these dermatomes of the shingles type rash. Okay. Let's see. I'm going to move on. This is just showing you a picture of what's occurring with the actual arc of the nerve response. I'm not going to spend a lot of time on infants and children in this particular lecture, because we will have a complete lecture on pediatric neurological assessment later on in the course. But one thing to remember is that in infants and children, the major brain growth and myelinization is occurring in that first year of life. At birth, the neurological impulses are primarily handled by the brain stem and spinal cord. They're basic impulses such as sucking, rooting, yawning, sneezing, hiccuping, blinking at bright lights, and withdrawing from painful stimuli at birth. These primitive reflexes that are present in newborn are called the startle reflex, or the Moro, the stepping reflex, palmar and plantar grasp. And remember that children tend to mature in a cephalocaudal direction, meaning from the head down towards the trunk and extremities. That's what's called cephalocaudal. Now remember that term, cephalocaudal, meaning from the head down towards the extremities. Brain growth continues until the age of around 12 to 15 years of age, and some sources say that the brain is not fully mature until into the 20s. So here's just some pictures of those primitive reflexes. This is the palmar grasp, plantar grasp, the Moro, or the startle reflex, and this is the stepping reflex, or placing is another term. This is the asymmetric tonic neck, or fencing, up to about 2 to 3 months is still present. In pregnant women, things occur during pregnancy. The neurohormonal changes occur with pregnancy that alters the neurological system, but are not well identified. But some of the alterations cause pregnant women to need more sleep time and napping, not to feel rested after sleep, and to have leg cramps and restless leg syndrome. In older adults, you do have a decrease of cerebral neurons with aging, but it does not necessarily cause deterioration of mental function, because we typically have vast numbers of reserve neurons, and so that we are born with. So it depends on other things as to whether that causes mental deterioration. However, we do know that the velocity, or the speed at which we are able to respond to impulses, declines with age. So in older adults, there is a slowed response time and a diminished sense of touch and pain perception. Okay, so one of the things that is important to do in terms of evaluating any system is the history. So the history is really important in determining what has been going on. So if you remember from our SOAP note lecture, the history of present illness basically tells us more information about the actual occurrence or the complaint that the person may be coming in for. So if history of present illness, we want to ask about whether a patient, if we're doing a complete, physical exam and history, and we're evaluating the neurological system, we want to ask about any history of seizures or convulsions. If they are having any of those kind of issues, what was the sequence of events? What seemed to trigger it? What was the character of the symptoms? Was there an aura? Was there an alteration in level of consciousness? Did they have any kind of automatism, such as eye fluttering, chewing, lip smacking, swallowing, etc.? We also want to ask about muscle tone, whether there was a post-ictal phase, and if there was, what kind of behavior was observed. Relationship of seizures to any other events, how often are seizures occurring, and whether there's medication such as anticonvulsants, and if they're taking their medication as prescribed, and if there's any other medicines that may have been started that might be interacting with these anticonvulsant medications. Pain is another symptom that we would want to evaluate. Pain is something that you will want to use your old carts with. We want to ask about onset, whether it was sudden or whether it was gradual or progressive. What is the quality? Where is the location of the pain? Are there other associated signs and symptoms? What was done to try to treat the pain? Was anything effective? What were the alleviating factors? What were the complicating factors? And what kind of medications were used? Gait or coordination. Ask about balance, falling, associated problems such as arthritis, stroke, seizure, and any other medications that may affect gait or balance. We want to ask about weakness or paresthesias. Are they having any weakness? Are they having any paresthesias? If they are, when was the onset? What is the character? Is it generalized or is it specific to some particular area of the body? Are there other associated symptoms such as tingling, numbness, confusion, difficulty speaking, difficulty understanding speech, any severe headaches, any vision loss or impaired vision, any loss of bowel or bladder control? We want to think about concurrent chronic illnesses such as HIV. We want to think about their nutritional or vitamin deficiencies. And we also want to take a look at all medications. Some of these particular medicines can cause weakness or paresthesias. Another history of presenting illness, tremor. Is this onset sudden or gradual? What is the character of this tremor? Is it worse with rest, or is it worse whenever there is intentional movement? That's a real key when you're evaluating tremor. Are there associated problems, such as do they have a metabolic problem, such as hyperthyroidism? Do they have a familial tremor? Is there a family history of such a thing? Do they have any chronic liver or kidney problems? Do they consume a lot of alcohol? Are there other factors such as multiple sclerosis? I want to ask about the tremor and whether it's relieved by rest, whether it's relieved by activity, or whether it's relieved by drinking alcohol. And then ask about medications, in particular neuroleptics, anti-seizure medicines, whether they're on any kind of medicines that can cause tremors, such as albuterol, pseudoephedrine, antiarrhythmics, steroids and how much caffeine are they intake do they have. Past medical history. When we're evaluating the neurological system, we want to ask about any previous trauma, any brain or spinal cord injuries, any localized injuries, any history of meningitis, encephalitis, poisoning, polio, any deformities or congenital anomalies, any genetic syndromes. Have they had any cardiovascular or circulatory problems, any strokes, neurological disorders, brain surgeries, or any residual effects from that. Family history, be sure to include any hereditary diseases or genetic conditions. Be sure to ask about family history of alcoholism, mental retardation, epilepsy or seizure disorders, migraine headaches, any other kind of headaches, Alzheimer's disease or dementia, learning disabilities, weakness or gait disorders, or metabolic disorders. In our personal and social history, again, you'll be asking about the environment and any occupational hazards, any kind of hand-eye-foot dominance, family patterns, or dexterity. Now, why do you think that might be important? Well, it's important to know hand, eye, or foot dominance because that can actually, people can have a little bit of a difference in their strength because of dominance. So it's good to know that in your personal and social history. If they're having any problems with self-care, are they needing assistance for activities of daily living? What are their sleeping and eating patterns, and whether or not they use alcohol and other drugs. In infants, it's important to note their prenatal history and any birth history, whether there was any trauma at birth, what type of birth, was it vaginal or C-section, any respiratory problems at birth, any congenital anomalies or developmental delays. In children, note the developmental milestones and the age that they attain those. Developmental milestones such as sitting, standing, crawling, rolling over, smiling, etc. Also, the pattern of development, whether it was slower or faster than other children their age, performance of self-care activities, dressing, toileting, feeding, any activities such as hyperactivity or impulsive behavior, any other health problems, headaches, seizures, falling, unsteady gait, any symptoms that would indicate muscle weaknesses or trouble getting up from the floor. Those are important to note in children. And in pregnant women, we want to think about weeks of gestation or estimated date of delivery, whether they've had any seizure activity in the past, or any pregnancy-induced hypertension, any frequency, duration, character of movement, if they do have seizures, any headaches, and their nutritional status. In older adults, whether they're having increased falls, they're stumbling, any unsteadiness of gait, any tremors, decreased agility, whether they're having trouble with their activities of daily living, any hearing loss, vision deficits, any fecal or urinary incontinence, any transient neurological deficits may indicate that they are having TIAs. All right, so let's move on to the exam. So the big part of the NeuroExam is to actually evaluate the mental status. This is covered in depth in another lecture, so I won't focus on that. But remember, the mental status is going to include the level of consciousness, their attention, and their memory. We'll also examine the cranial nerves, proprioception and cerebellar function, sensory function, reflexes, and muscle tone, which is most often examined during the musculoskeletal exam part. but can be done as part of a complete neurological exam. So mental status screening, we're going to look at their appearance and their behavior and note things such as grooming, whether they're dressed appropriately for the weather conditions or for the particular time of day, their emotional status, their body language, their affect. We're going to look at their cognitive abilities such as level of consciousness, their memory, and much of this can be determined just in general speech by asking them their birth date and their past medical history and asking them about their children and about current events. You don't have to basically ask them, who is the president and blah, 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 which is, in someone who's sitting there talking with you, you wouldn't necessarily have to ask those questions in that way. You could determine their cognitive abilities just through speech and their vocabulary and their responses to your general questions. Sometimes you may want to go deeper into evaluating cognitive abilities such as memory, and then calculations that would test their abstract thinking, and then sometimes judgment. There will be some things that you might want to evaluate, but these are specific tools that are used to assess cognitive abilities. Emotional stability, we would want to ask about mood and feelings, thought processes, and perceptions. In children and infants, their general behavior and their level of consciousness is how we determine mental status. Observe activities in response to the environment. How do they interact with their caregiver? Do they seem at ease? Are they anxious? Are they, in duress? Are they crying? Are they drooling? What is the character of their cry? Is it a strong, solid cry? Or are they weak? And then we want to do our Denver developmental screening to look at those developmental milestones. So we want you to remember these different levels of consciousness, because you will see this on the test. In particular, pay attention to the difference between obtunded and stupor or coma. So all of us are familiar with these words, but it may be it's just a little difference in a slight difference between some of these particular words. So look at alert, meaning your eyes are open, you respond fully. Lethargic, you may appear drowsy, but you can open your eyes and respond to questions. Obtunded means that it's harder to arouse you. You may actually have to shake somebody to arouse them, but they would open their eyes, but they may respond slowly. They may be confused. They may actually have a decreased interest in the environment around them. That would be obtunded. Stupor is when someone arouses only after painful stimuli, such as a rub on the sternum or a pinch of some sort. Verbal responses are either slow or absence. And then coma is unarousable even to pain. So just remember the levels of consciousness. Mental status screening also look at speech and language voice quality. What is the quality of the speech? What is the quantity of the speech and language? Whether they're articulate, whether they're fluent, whether they are comprehending, whether they appear coherent and are answering appropriately to the questions that you're asking. And then whether or not they're having trouble with responding or understanding your speech, aphasia. Then the cranial nerves, as we went through already. 1 is olfactory or sense of smell. 2, visual acuity and visual fields. 3 is one of the cranial nerves responsible for the extraocular movements. It's called oculomotor. It also is responsible for pupillary constriction. the motor response to the corneal reflex, which is touching a wisp of cotton to the cornea. That's the motor response to the cornea, or the corneal reflex. That's different than the corneal light reflex, which we'll talk about later. But the motor response to the corneal reflex is controlled by the oculomotor or cranial nerve 3. The ability to open the eyes, or a droop of the lids, which is called ptosis, is also controlled by the oculomotor nerve. And then most of the extraocular movements, lateral and laterally and upward, so most of the extraocular movements are controlled by cranial nerve 3. This is how you would evaluate the sense of smell. Cranial nerve 4, or the trochlear, is responsible for the downward, inward movement of the eye. So it's responsible for one of the extraocular movements, the downward, inward movement. Cranial nerve 5, or the trigeminal nerve, is responsible for both motor and sensory function of the trigeminal area. The motor is temporal and masseter muscles, which is evaluated by jaw strength, or clenching the teeth, and the lateral movement of the jaw. Sensory, there are 3 divisions of the facial nerve: the ophthalmic, maxillary, and mandibular. And so you would evaluate those individually for sensation and superficial pain and touch. And then cranial nerve 6, or the abducens, is responsible for the lateral deviation of the eye. So cranial nerve 3, 4, and 6 are responsible for all 6 of the extraocular movements, or all 6 fields. So just remember, lateral is cranial nerve 6, downward, inward is cranial nerve 4, and all the rest are cranial nerve 3. This is the evaluation of the trigeminal nerve for motor function. You want to have the patient clench their teeth and then palpate the jaw, the muscles over the jaw, for tone. This is sensory function in the areas of the trigeminal nerve. In cranial nerve 7, the facial nerve, or the motor function, facial movements such as closing the eyes and mouth, and symmetry of facial features. So in the case of Bell's palsy, which is a damage of the peripheral facial nerve, you would have the entire face, including the forehead, is affected by damage to this superficial nerve. If it's a central lesion, such as in a stroke, only the lower part of the face is affected, so they're still able to raise their eyebrow or frown and close their eye on the affected side. So in other words, that's one of the ways that you can determine whether someone who has some facial paralysis actually has Bell's palsy or a stroke, is whether or not they can raise their eyebrows on the affected side and close their eye. And a patient with Bell's palsy is not able to do that. It's also responsible for sensory, sweet and salty, sour and bitter on the anterior 2/3 of the tongue. This is an examination of the cranial nerves. You want to ask them to raise their eyebrows, to smile, to puff their cheeks, to frown, to clench their jaws, to close their eyes tightly, and purse their lips and blow out. This is how you would evaluate all of the facial cranial nerve for motor function. Okay. Acoustic nerve is responsible for hearing, the cochlear division. We want to test for bone versus air conduction and for lateralization. We do this through the Weber and Rene test. The Rene is spelled R-H-I-N-N-E. And then balance, the vestibular division. Cranial nerve 9, glossopharyngeal, is a mixed nerve. It's responsible for taste and swallowing. Test the tongue for sour and bitter, and test the gag reflex and the swallow reflex. It's also responsible for the sensory part of the eardrum and canal and the pharynx and posterior part of the tongue. Cranial nerve 10, a vagus nerve, is a mixed nerve, swallowing and speech. You want to inspect the palate and the uvula for symmetry. You're going to look to see that the palate rises symmetrically when they say ah. You're going to inspect for any kind of swallowing difficulties by having the patient swallow. You're going to evaluate for any kind of speech difficulties and evaluate for guttural type speech sounds. The symmetry of the palate with the gag reflex, the pharynx and the larynx, and then sensory, the pharynx and the larynx. The spinal accessory, or cranial nerve 11, it has motor and muscle strength. You're going to test the trapezius and sternocleidomastoid muscle strength, and you test that by having the patient raise their shoulders against resistance, and also turn their head towards your hand against resistance. The hypoglossal, or cranial nerve 12, motor and tongue strength. You're going to inspect the tongue for symmetry in the mouth. Is it laying symmetrical when they stick out their tongue? Does it protrude in one direction or the other? You're going to look for tremors. You're going to look for atrophy movements. You're going to have them touch their tongue inside their cheek and test the strength of the tongue and evaluate their speech sounds. So this is examination of the hypoglossal cranial nerve, the protruded tongue for size, shape, symmetry, and any kind of fasciculation or funny movements. And then you're going to observe the movement of the tongue from side to side. Motor system, we want to look for body position and movement, any tremors, tics, fasciculations, muscle bulk and tone and strength are graded on a 0 to 5 scale, 5 being normal strength and tone, 3 being able to raise against gravity, and 0, no contraction at all detected, or not able to move muscles at all. Coordination, we want to test by doing the rapid alternating movements and the point-to-point, such as touching their finger to your finger as you move it in space. So point-to-point movements or rapid alternating movements. We're also going to test the motor system and by checking their gait, having them do the tandem walk or the heel-to-toe walk, tiptoes, walking on their heels, hop, knee bends, rising from sitting position, or stepping up on a stool are all ways that we evaluate their gait and strength. And then we're going to look at the Romberg and the pronator drift to evaluate position sense and balance. Impaired strength is called weakness or paresis. Absence of strength is called paralysis or plegia. So remember the terms hemiplegia, paraplegia, quadriplegia, meaning absence of strength, or paralysis, either in half or all of the body. And hemiparesis meaning a weakness. So hemiparesis means that they would have weakness in one side of the body. We're going to test strength against resistance, then against gravity, and then without gravity by passive movement. Muscle strength, also we check for elbow flexion and extension, wrist extension, grip strengths. So when we're testing flexion, we're checking C5 and 6 are the biceps, and extension is C6, 7, and 8 or triceps. Wrist extension, C6, 7, and 8, radial nerve, weakness in the radial nerve damage. Grip strength, we're going to be checking for C7, 8, and T1. We want to check both sides simultaneously to evaluate strength by having them grip your fingers together. Weakness due to central peripheral nervous system disease would be an indication of an asymmetrical grip strength. In muscle strength, we're going to check finger abduction. Remember the terms abduction and adduction. Abduction is away from, and adduction is towards. So finger abduction would be testing C8, T1, and ulnar nerve, and we're looking for weaknesses in the ulnar nerve disorders. Thumb opposition, whether they can touch their thumb to the little finger in opposition, is testing C8, T1, and median nerve. We can have weaknesses in the median nerve disorders such as carpal tunnel syndrome. We're also going to check hip flexion, which is testing L2, 3, 4, and the iliopsoas muscle. Hip adduction, which is towards midline, L2, 3, 4, and the adductor muscles. And abduction, which is L4, 5, and S1, which is gluteus medius and minus. Hip extension, S1, gluteus maximus. Proximal weakness can indicate some myopathy or muscle disorder, whereas distal weakness could be polyneuropathy or peripheral nerves issues. All of these you'll be doing as you do your complete physical exam. So you'll be doing these range of motion, but not only range of motion, but also testing muscle strength. So when you're doing your exam, you'll want to have the patient move their hip and bend their knees either passively and against resistance to check for strength. You'll also be testing for knee extension and knee flexion, and those are evaluating the L2, 3, 4, and L4, 5, both the quadriceps and hamstring muscles, foot dorsiflexion, and foot plantar flexion. Dorsiflexion is L4, 5, and plantar flexion is S1. Coordination requires 4 areas of the nervous system to function in an integrated way. We need the motor system for strength, the cerebellar system for rhythmic movement and steady posture, the vestibular system for balance and coordination of the eye, head, and body movements, and then the sensory system for position sense. So coordination requires all of these areas to function together. We would test coordination with the rapid alternating movements, point-to-point movements, gait, and other body movements, and standing in specified ways. We test proprioception or cerebellar function with the Romberg test, which tests the position sense. Pronator drift. This is done by having the patient shut their eyes and hold out their arms in front of them, and you tap the arms briskly downward and see if they return back to where they were in position smoothly, to where they were previously. That's what we call the pronator drift. Someone with a neurological deficit, when they shut their eyes and put their arms in front of them, may actually start to have a drift of one arm or another without actually knowing that that's occurring. Gait, or they wouldn't be able to go back to where their arms were if you tapped them down. They would not be able to go back to the previous position. In order to evaluate gait, we're going to have them walk for us. We're going to have them do the heel to toe or tandem walk on their toes and heels, and look at their gait. Coordination and fine motor skills with rapid, rhythmic, alternating movements, and then accuracy of movements with the finger to finger, finger to nose, and then heel down the shin to see if they are able to have accurate movements. Okay, these are pictures that are in your book of that. Sensory function is evaluated through superficial touch and pain and temperature and vibration. The 128 Hertz tuning fork is best to evaluate vibration. It's best done at the pad of the great toe, not on the bone. We usually do this to evaluate for peripheral neuropathy in patients with diabetes, alcoholism, tertiary syphilis, or B12 deficiency. And then we also test the position of joints to see if patients can tell you where in space their joint is, like by moving a finger or a toe. Cortical sensory function is evaluated through stereognosis, which is describing an object that's placed in your hand. 2-point discrimination, where you actually touch the person in 2 points and get closer and closer and closer until they can't discriminate between the 2 points. Point localization, whether they can tell you where exactly they have been touched. Graphesthesia, as we talked about earlier, drawing something in someone's palm and they're able to tell you what it is. And extinction is stimulating both sides of the body simultaneously and asking how many stimuli and where they are. Similar sensations should be felt on both sides at the same time. Reflexes, both superficial and deep, are used to evaluate the function of specific spinal segments. And again, we'll go over these in more detail, but the superficial reflexes, the abdominal reflex above the umbilicus evaluates T8, 9, and 10. Below the umbilicus, T10, 11, and 12. So you can see that there's a little overlap. Cremasteric, which is a reflex that's done on men or boys only. Lightly stroke the superior medial part of the thigh in a downward direction. Then the normal response is that the scrotum rises on the side that is stroked. The cremaster muscle pulls up the scrotum and the testes on that side, and so you'll see a rise of the scrotum when you touch the inner thigh. That indicates an intact cremasteric reflex. This is typically done to evaluate for testicular torsion. So it's been reported to be absent in 100% of cases of testicular torsion. It's also done to evaluate upper and lower motor neuron disorders, as well as spinal injuries in L1 and 2. The plantar reflex is one that is not necessarily done on someone who's alert and walking and talking around. You may do this to evaluate someone who has neurological deficits. But the plantar reflex evaluates L5, S1, and S2. Dorsiflexion of the big toe is a positive Babinski response. This test is often mislabeled as the Babinski test or the Babinski reflex. It's really not. It's a plantar reflex and a Babinski response. If you get a positive response, it's called Babinski. So the dorsiflexion of the big toe is a positive Babinski response. The plantar reflex, stroke the lateral side of the foot from across the heel to the ball and then curve across the ball of the foot, and the patient should have plantar flexion of all toes, not dorsiflexion of the big toe. So if you see that dorsiflexion of the great toe with or without fanning of the other toes, then it indicates a problem or a positive Babinski sign. This finding is actually normal in children less than 2 years of age. Here's a picture of how you do the abdominal reflexes and the plantar reflex. The other deep tendon reflexes, the biceps, brachioradialis, triceps, patellar, Achilles, and then testing for clonus. So the biceps is checking C5 and 6, brachioradialis or supinator, C5 and 6, triceps C6 and 7, patellar L2, 3, and 4, Achilles or ankle is S1, and plantar is L5, S1. Clonus is testing for hyperactive reflexes whenever the ankle is put in trying to think of the word here. So when you test for ankle clonus, you basically flex the patient's foot, and then you kind of flex it, relax it, flex it, and then flex it really hard, and watch for sustained clonus activity, which is basically like a seizure, where the muscle just goes into sustained movement. That's what we call clonus. These are the locations of the tendons for evaluating the deep tendon reflex. We'll be going over this in lab and helping you evaluate where to check the deep tendons. But as you can see, it's important to put your finger kind of in the fold of the antecubital space to check for the biceps. The brachioradialis is about a couple of inches above the wrist. The triceps is holding the arm up and evaluating a couple of inches above the elbow. There's a little groove just above the bone, just below the patella, that you check for the patellar reflex. And the Achilles will be demonstrating, but basically you want to flex the foot slightly and hit right at the Achilles area, and watch for a downward push of the foot against your hand. And it's how you can do an Achilles tendon reflex. So this is how you rate the deep tendon reflexes. Normal is 2+, or that's what's to be expected. If they're kind of sluggish or diminished, that would be 1+, or no response, 0. And 5, all the way up to 5, which is sustained clonus. Sensory function is tested with the patient's eyes closed. You're going to observe side-to-side differences, interpretation of sensation, discrimination, location, and map that by dermatome. Superficial touch by cotton wisp or fingertip. Superficial pain can be determined with a broken tongue blade or the point of a sterile needle. Temperature or deep pressure are usually only tested when other superficial pain sensation is not intact. Vibration using a tuning fork and position of joints razor lowering the joints. And here's pictures of how that is evaluated. Evaluate sensory function and cognitive ability to interpret sensations. An inability to perform these tests should make you suspect that there's a lesion either in the sensory cortex or the posterior columns of the spinal cord. Stereognosis we've talked about. 2-point discrimination, the distance at which the patient can no longer distinguish between 2 points. And that varies depending on the part of the body. But in general, should be able to get very close and still be able to distinguish 2 points. We already talked about the extinction phenomenon and graphesthesia and point location. And here's pictures basically of how that is evaluated. So you can see here in picture B, the 2-point discrimination. You're using 2 needles or 2 points of a paper clip and asking them to determine where they are simultaneously on the skin, whether they have 1 or 2 sensations. And then you get smaller and smaller until they can no longer distinguish between 1 or 2 points. This is a picture, some slides on different types of gait, and you can read about these in the actual slide itself, but there's links here that will take you to a video of these particular types of gait. Someone who's actually demonstrating the gait itself. So you can see here that the spastic gait, they're dragging their foot. That's one of the indicators of a spastic gait, and their affected arm is flexed and adducted, which can indicate either an upper motor neuron lesion such as a stroke. This is a scissors gait or spastic diplegia. They have spasticity in both lower extremities. This is a common type gait in neurological conditions such as cerebral palsy. This is what's called the neuropathic or the steppage gait. This is seen in some of the peripheral neuropathies. Patients who might have foot drop or weak dorsiflexors, they attempt to lift their leg high enough to prevent the dragging of their foot on the floor. These patients are not able to walk on their heels, and sometimes they can be caused by a L5 radiculopathy, or if it's bilateral, it can be from ALS or some other kinds of peripheral neuropathies. The waddling or myopathic gait is common in patients with weak pelvic girdle muscles and hip abductor muscles. They have to keep their legs apart, and their weight is shifted from side to side in a waddling type motion. They also have a protrusion of their abdomen and a lordosis. And then cerebellar ataxia. This is something that is similar to someone who would have acute alcohol intoxication. They basically can't perform that heel to toe or tandem walk, and they can't walk in a straight line. Their feet are widely based. They kind of stagger and they're clumsy, and they kind of lurch from side to side, often swaying. This is often and commonly seen in someone who may have a cerebellar disease or alcohol. Sensory ataxia. Their gait is wide-based. Their feet are thrown forward and outward. They bring down first on the heel and then on the toes. They watch the ground to guide their steps. They would have a positive Romberg. And it's often seen in disorders of the dorsal column such as B12 deficiencies or peripheral neuropathy due to diabetes. Parkinsonian gait. This is a gait that's very noticeable and specific to Parkinson's. They have a stooped posture with their head and neck forward and their knees flexed. Their body's kind of held rigid, and they have slow, shuffling, short steps, and they're called marche à petit pas, or walk of the little steps. They're hesitating, starting and stopping, and you can see this from other things besides Parkinson's, such as some types of drugs which cause Parkinson-like symptoms. And then choreiform or hyperkinetic gait is often seen in things like Huntington's chorea. And so just review these different types of gaits. This is how you do a monofilament test for patients with diabetes. You'll be testing different areas of the foot with this thin piece of monofilament similar to fishing line, and to see if they are able to sense that. Just enough pressure to bend the monofilament, and they should be able to feel that in all of these areas. If they're able to feel that, then that's a normal exam. Other things to remember in the neurological exam that you will want to check for nuchal rigidity, a sign that may be associated with meningitis and intracranial hemorrhage. You're going to slip your hand under their head and raise it while flexing the neck. Pain and resistance to neck motion are associated with nuchal rigidity. And oftentimes the patient will even try to bring up their knees to alleviate that stretching of the neck and meninges. Other meningeal signs, Brzezinski's sign, may be present when neck stiffness is assessed. That can also indicate meningeal irritation. This is an involuntary flexion of the hips and knees when flexing the neck. That's called a positive Brzezinski. Kernig may indicate meningeal irritation. This is evaluated by flexing the leg at the knee and hip when the patient is lying down, and then attempting to straighten the leg. Pain in the lower back and resistance to straightening the leg at the knee is a positive Kernig sign. Here is the Brzezinski on the left. You see here involuntary flexion of the hip and knees is a positive Brzezinski. And Koenig's flex the leg at the hip, at the knee and the hip when the patient is lying down, and then try to straighten the leg up completely, and observe for pain in the lower back and resistance to the straightening of the leg. When it's bilateral, it suggests meningeal irritation. If it's unilateral, it can indicate a nerve root irritation or a herniated disc. Other things to think about: asterixis, the stop traffic, sudden brief non-rhythmic flexion of the hands and fingers, and then winging of the scapulas, indicating a muscle weakness and deinnervation of the areas in the back and below the scapula. Suggests weakness of the serratus anterior muscle, as in muscular dystrophy. Okay, so cranial nerves can be indirectly assessed in infants by observing the blink, the gaze, doll's eye, rooting, and sucking. Facial expressions, forehead wrinkling, smiling, acoustic blink reflex, doll's eye maneuver for 8. 9 and 10 was swallowing and gagging. 12, sucking, swallowing, tongue position, and pinched chest. Spontaneous activity for symmetry and smoothness of movement. Coordinated sucking and swallowing is a function of the cerebellum. Withdrawal from painful stimuli is sensory integration. Patellar tendon reflexes are present at birth, and the Achilles and brachioradial tendon reflexes appear at about 6 months. Posture and movement are routinely evaluated by the primitive reflexes that we went over earlier: the palmar grasp, the plantar grasp, the moro, placing, stepping, tonic neck, up to age 2 to 3 months. And then inspecting for muscle strength and tone. Observe children's neuromuscular development and their progression and skills displayed during physical exam. You want to look at their developmental level. You do modify your exam according to their age and observe them at play, looking at gait, fine motor coordination, heel to toe, hopping, jumping, skipping, walking, coloring, writing, drawing. Those are ways to observe and check child's neurological condition. Okay. Older adults, same as for adults, but sometimes medications can impair central nervous system function. Remember, slowed reaction time in older adults, but medications can also cause that and also cause tremors and anxiety. Test the gait for decreases in speed, balance, and grace. Vibratory and tactile sense for impairment, and deep tendon reflexes for diminished response. Okay. Let's see. I'm going to let you take a look at these disorders. I think that these are covered in your book as well. Just thinking about stroke, can be ischemic or hemorrhagic, and we need to determine which kind so that we determine the treatment. peripheral nervous disorders such as myasthenia gravis and Guillain-Barré. You would want to look at those in your book. Typically, Guillain-Barré follows some sort of nonspecific gastrointestinal or upper respiratory infection. Trigeminal neuralgia, recurrent paroxysmal sharp pain that radiates into one or more branches of the fifth cranial nerve. You may see patients coming in with this recurring pain in the fifth cranial nerve. And then Bell's palsy is something that you'll run across fairly often. Usually is temporary, and but it can be permanent. It's a acute paralysis or weakness of one side of the face. And here's some pictures of Bell's palsy. You can see here on this particular picture, it's really a lot more clear. You might think that this is the affected side of the face, but actually this is the affected side. Okay, the side over here with no wrinkles. Basically, the patient, when trying to smile, can smile on this side of the face, and forehead is wrinkled here and eyebrow is raised here. This side of the face is completely paralyzed. This is typical of Bell's palsy. They're unable to raise this eyebrow, and they have no lines in the forehead here. You can see here as well. She's trying really, really hard to raise her eyebrow on this side, but is unable to do so. So this is very typical of Bell's palsy. Peripheral neuropathy can be caused by other types of metabolic disorders. It results in motor and sensory loss and a distribution of one or more nerves. Diabetes, B12 or folate deficiency, Lyme disease, HIV infections can all cause peripheral neuropathy. Shaken baby syndrome is something you may or may not have heard about, but it's a severe form of child abuse resulting from the violent shaking of infants under a year of age, which causes stretching and tearing of nerve tissue and blood vessels, can cause brain damage, and subdural hematoma can also damage the spinal cord. Okay, Parkinson's. One of the things to be aware of with Parkinson's, let's go back here. It's a slow progressive degenerative disorder. It is caused by deficiency of the neurotransmitter dopamine. It results in poor communication between parts of the brain that coordinate and control movement and balance. So you can see this is kind of the faces that you see with Parkinson's. They have excessive sweating, sometimes drooling, and their gait is that head bent forward, stooped posture with a shuffling little tiny step gait. And that concludes the neurological exam lecture. I will be uploading some videos that will assist you in performing the neurological examination and helping you practice those skills. Please let us know if you have any questions. Thank you for your attention. Bye-bye.